Hi, my name's David Elson. I'm a knee surgeon working in Gateshead, and the reason I'm talking to you today is because I'm going to speak a little bit about joint operations and how they've helped me in my practice as a consultant. I think I've been a consultant for about 3 years now, and I've worked extensively with joint operations at different stages during my practice as it's evolved. My background is as an osteotomist, which is I trained with Adrian Wilson and Chris Wilson on fellowship. So I had an interest in biological knee surgery, but that has developed a little bit since I've become a consultant. I was going to talk to you a little bit about a case which I've just got here, which is a good example of how joint operations have been involved in this patient's care. So this is a case of a 28-year-old female patient who presented with medial compartment pain, which you can see on this MRI scan here as I scroll through the images. When we look at her alignment, which is shown in these long leg views, she's not massively invarus, so she'd be somebody who'd be for a small osteotomy. And she's also a female with quite small bones, and so she's somebody who, for me, was well suited to having the nuclear plate applied because it has a much lower profile than the more standard Tomofix plate. So she needed offloading of the area where she's got the wear on the medial femoral condyle. The best way to do that was through a medial opening wedge high tibial osteotomy, which I did for her about 8 weeks ago. Case went very well. I've used some allograft bone graft, which joint operation do supply, and in addition I've put on one of the nuclear plates. So when I looked inside her knee, she had a lesion on the medial femoral condyle, and I was at the same procedure. I was able to perform an autologous matrix-induced chondrogenesis, which is a bit of a mouthful. We use the word AMIC for short, and what that really is just a membrane of a bilaminar scaffold by a company called Guide Slitch Surgery, and joint operations supply the chondroguide which I use. That goes over a microfractured bed in a discrete lesion, and I have looked into several people's knees after they've had that done, and they do all go on to produce healthy cartilage after that, which is really quite miraculous. Together with the effect of offloading, I think that's going to try and stand her in good stead for the future. However, when I looked inside her knee as well, she's actually deficient of the meniscus, having had 2 previous surgeries in the past. So I'm waiting for her to get over this operation, and in future I'm thinking about providing her with a meniscal transplant. My plan would be to take that meniscal transplant and put it in at the same time as I've actually taken the plate off, so probably in about 8 months to a year or so. Joint operations are able to find meniscal transplant tissue for me, so I'll be asking them to look for some sizes through Allosource and JRF. With regard to ligaments, there have been occasions when I've needed to use allograft tissue for revision cases or for posterior cruciate ligaments, where I would routinely use allograft for a primary PCL reconstruction, and joint operations have been able to source some tissue for me without particular problems. And what I like about the tissue that I get is it's always reliably exactly the length that I've been told it's going to get, so it's completely reliable when you open the packet and very usable. Thank you.